Hi everyone. Today's topic is electrical activity of the heart and events of the cardiac cycle. We have a fairly multidisciplinary group here, but an understanding of the physiology of these events is fairly fundamental to all your professions. So the bulk of the heart is made up of contractile cardiac muscle, but about 1% of myocardial cells are autorhythmic cells called pacemaker cells. These cells generate action potential spontaneously and are the drivers of cardiac muscle contraction. They account for a unique property of the heart, which is its ability to spontaneously contract without any outside neuronal signal. So I'm going to assume that you guys have a basic understanding of action potentials from the pre-reading as well as your other lectures. But action potentials in these autorhythmic pacemaker cells are quite different from the ones that govern skeletal muscle contraction because they are unstable and don't rest at a constant value. Instead, they are in a constant state of depolarization, and once this depolarization reaches a certain threshold, the autorhythmic cells fire an action potential, in turn resulting in cardiac muscle contraction. So the reason for this unstable membrane potential is thought to be due to the presence of so-called funny current channels that are permeable to both sodium and potassium. These channels open when the membrane potential is at -60. So um, funny channels gradually close and calcium channels open, which results in this steep depolarization that you see here, which is due to the influx of calcium. And similar to what occurs in skeletal muscle, repolarization is due to the opening of potassium channels, in turn resulting in potassium efflux. There are also some differences between contractile myocardial muscle action potentials compared with skeletal muscle, mainly that there is a longer action potential with this plateau here due to calcium influx, and that depolarization spreads via gap junctions, which are cytoplasmic bridges between adjacent cells as opposed to neuronal input of acetylcholine. So the influx of calcium prolongs the duration of an action potential. To put this in perspective, a skeletal muscle action potential lasts between 1 and 5 milliseconds, while a myocardial contractile cell action potential lasts 200 milliseconds or more. This longer action potential is important to prevent tetanus or prolonged contraction that often occurs in skeletal muscle. So this is important to allow cardiac muscles to relax between contractions so that ventricles can fill with blood. So in skeletal muscles, tetanus can occur because an action potential can fire immediately after a refractory period. In cardiac muscle, tetanus cannot occur because the refractory period and contraction end simultaneously. By the time a second action potential takes place, the myocardial cell has almost completely relaxed. So this table from Silverthorne nicely summarizes the differences in action potential between the three types of cells. The main points I want you to take away are that um, membrane potential in autorhythmic cells is unstable due to the presence of funny current channels, and also in terms of the events leading to threshold potential, depolarization in contractile myocardial cells enters via gap junctions as opposed to neuronal input of acetylcholine seen in skeletal muscle. In contrast to the other two, the rising phase of the action potential in autorhythmic cells is due to calcium entry, not sodium entry, and that cardiac cells have a much longer action potential and a longer refractory period. So now that we have a basic understanding that the signal for contraction of cardiac muscle cells originates from autorhythmic pacemaker cells, I would like to launch into the events of electrical conduction in the heart. As you will see, autorhythmic cells are fundamental to the heart contracting in a coordinated fashion. Electrical conduction can be broken down into 5 steps, with the direction being from atrium to ventricle. So, in the first step, depolarization begins at a group of autorhythmic cells called the sinoatrial node in the right atrium. These are the cells that determine heart rate because they are the fastest pacemaker cells. In the second step, this depolarization then spreads via the internodal pathway to another group of autorhythmic cells called the atrioventricular node near the floor of the right atrium. Again, reiterating, depolarization spreads to adjacent cells via gap junctions. Depolarization in the third step then spreads across the atria through the AV node. The fibrous skeleton at the junction of atria and ventricles prevent electrical signals from passing down any pathway apart from the AV node. This is really important to ensure that the ventricles contract from the bottom to the top, preventing blood from being squeezed downwards instead of at the top of the ventricles where atria are located. A second important function of the AV node is to delay transmission of action potentials, since conduction slows across the AV node, allowing the atria to complete their contraction before ventricular contraction begins. From the AV node, depolarization moves through the ventricular conducting system to the apex of the heart. Purkinje fibers, which are specialized conducting cells, transmit electrical signals very rapidly down the atrioventricular bundles. Finally, a depolarization wave spreads upward from the apex. So this coordinated myocardial contraction is essential for normal cardiac function. Fibrillation occurs when myocardial cells contract in a disorganized manner. While atrial fibrillation is quite a common condition without any symptoms, although it can become very serious if left untreated, ventricular fibrillation is immediately life-threatening, and in the next lecture I will ask you why you think this might be the case. So I mentioned to you that SA nodal cells determine heart rate because they are the fastest autorhythmic cells. In complete heart block, electrical signals from the SA node are blocked due to a failure of AV node, so ventricles coordinate with the next fastest pacemaker. Because ventricular autorhythmic cells are much slower and may be too slow to maintain adequate blood flow, it may be necessary for the heart's rhythm to be set artificially by a surgically implanted pacemaker. For most of you, however, the most important clinical scenario for which you will need this knowledge is when you read electrocardiograms. An ECG trace shows the summed electrical potentials generated by all cells of the heart. Different components of an ECG represent depolarization or repolarization of atria and ventricles. There are 3 major components of an ECG. So there is a P wave, which corresponds to the depolarization of the atria. a QRS segment, which represents the progressive wave of ventricular depolarization, and a T wave, which represents repolarization of ventricles. Importantly, you can't tell if an ECG recording represents repolarization or depolarization by looking at the shape of the wave. For example, a P wave represents atrial depolarization and a T wave represents ventricular repolarization, but both deflections are above the baseline. So an ECG can provide information about heart rate and rhythm, conduction velocity, and the condition of tissues in the heart. For example, in the condition of complete heart block I mentioned earlier, in which action potentials from the SA node fail to be transmitted to ventricles, a P wave can occur without a QRS complex. Another heart condition that can be seen on an ECG is a long QTS syndrome, named for its change in the QT interval due to defects in sodium and potassium channels. So that you can understand an ECG, we need to go through the events of a single relaxation contraction cycle of the heart, known as the cardiac cycle. So we'll start off with late diastole, when both atria and ventricles are relaxing and filling passively. The atria are filling with blood from the veins, and the ventricles have just completed a contraction. As the ventricles relax, the AV valves between the atria and the ventricles are open, and thus blood flows via gravity into the ventricles. Atrial systole. So although most blood enters the ventricles from the atria via gravity, the last 20% of filling is accomplished when the atria contract and push blood into the ventricles. The next step is called isovolumic ventricular contraction. As the atria are contracting, the depolarization wave is moving through the conducting cells of the AV node, then rapidly down the Purkinje fibers to the apex of the heart. Blood pushing against the AV valves pushes them shut, and the semilunar valves between the ventricles and the arteries are also shut. As valves on both sides of the ventricles are shut, but the ventricles are still contracting, this phase is called isovolumic contraction to reflect the fact that the volume of blood in the ventricles is not changing. The ventricles at this stage have often been likened to squeezing on a toothpaste tube with the lid shut. High pressure develops in the tube, but the toothpaste has nowhere to go. Ventricular injection. As the ventricles contract, they generate enough pressure to open the semilunar valves and push blood into the arteries. The last stage is isovolumic ventricular relaxation. At the end of ventricular ejection, the ventricles begin to repolarize and relax. As they do, ventricular pressure decreases. Once ventricular pressure falls below pressure in the arteries, blood flows backward into the heart. This causes the cup-like cusp of the semilunar valves to close. So, a fun fact, the first lub of the lub-dub sound you typically hear on a stethoscope are the AV valves closing, and the dub is the semilunar valves closing. So I'd like to thank you for your attention today. I'll leave you with this figure from Silverthorne that nicely superimposes an ECG trace with events of the cardiac cycle as well as pressure in the various compartments. I know it's a lot of detail to take in, but I hope you get the sense that the events are quite logical, which should help you remember them. So, any questions?